I'm Dr. Pamela Stewart, and I'm the emergency director at St. Louis Regional Hospital. I've been there now for 21 years.
21 years.
Yes.
Great.
My name is Robert Schambach. I'm the nurse director at St. Louis Emergency Department. I've been there for 3 years.
I'm Dean Didich. I'm a pediatrician and the chief medical officer of the DCHS Medical Foundation. I've been with them since they started in April of 2012.
I'm Scott Thompson Baker. I am the emergency department manager at O'Connor, and I've been there for a little over a year.
I'm Dr. Manesh Bhamani. I'm the medical director of the emergency department at O'Connor Hospital, San Jose. I've been there since 2006, and I've been medical director since for the past 2 years.
So our first question.
And actually, James, not to slight the urgent care, I also forgot to tell you that I'm also the director at the DePaul Urgent Care, since we're talking about that today.
Okay, terrific. Thank you. So the first question is for Dr. Stewart and Dr. Bhamani, and it is, can you tell us what the actual difference is between an emergency department and urgent care? And why don't we start here?
Sure. People know the emergency department because that's the place of last resort for many. But emergency departments serve those patients who have injuries to life or limb. We tend to see many other types of injuries or illnesses as well, whereas the urgent care treats patients who also may have injuries or illnesses of a lesser nature. They obviously treat more complex conditions than a regular doctor's office would, but at the same time they don't have the facilities to do true emergency care.
Dr. Bhamani?
So I would second that. In that I think the critical difference between the emergency department and urgent care is the severity of illness that it's capable of taking care of. So the emergency department's kind of in broad words, we take care of everything. Are capable of taking care of everything. Urgent cares are capable of a well-equipped urgent care, I would say, is capable of taking care of many of the patients that come to the emergency department.
Okay.
But they're most equipped to take care of those with kind of lesser severity of illness.
Right. So the next question I want to ask, and again, if the question is not directed specifically to you, if you'd like to chime in, feel free to do so. And again, Dr. Stewart, we'll start with you on this. Is one way to think of urgent care as an after-hours doctor's office?
And I'd say absolutely not.
Okay.
The doctor's offices are primarily for, at least a primary care doctor, is for ongoing care of their patients who they have a relationship with. In the urgent care, we're treating episodic care. And in the urgent care, their level of ability to care is much more complex than a regular doctor's office. But as Dr. Bhamani also said, it's not as capable of handling complex care. So the urgent care is not a doctor's office. It's able to handle illnesses or injuries such as small sprains or lacerations that a regular doctor's office won't.
Care?
Correct.
Okay.
Correct.
Okay. And Dr.
Well, in a primary care doctor's office, you do see sore throats, you see coughs, you see pneumonia, you see abdominal pain, you see things that are episodic. And it's nice because there's continuity of care. The urgent care are able to do those things, and I think that's why we think of it as a sort of an after-hours doctor's office. But they are able to handle lacerations and fractures and much more complex problems than many primary care doctors can manage these days.
Scott, do you want to add to that?
I think the same thing. I think that the urgent care centers are able to handle a different variety of patients than what the doctor's offices can. I see that more often they're used a little bit more because I think that the physician's offices book their appointments all day, and parents that can't get their children in during the day will look for an urgent care or a emergency department to seek their care after hours. But it is similar in what they can do. I think even in the doctor's office, some doctor's offices sutures, some do small IND of abscesses and types of things. Same thing that urgent care would do, and same thing that the emergency department would. But I think it's how people have gotten to use, have become comfortable with using the services based on if they can't get in with their primary care doctor during the day or on the weekends, they'll go to the urgent care or the ER.
Okay. So I want to give you scenario here. If I sprain my ankle, should I go to urgent care or the emergency department, and why? Dr. Bhamani.
So I think the first thing that we would say is generally when people have an injury like that, the first question that they're trying to answer is, did I break my ankle or not? Okay, I think urgent care, and I say this with the caveat, a well-equipped urgent care, because urgent cares are very different than emergency departments. Emergency departments, the care is relatively standardized as far as the facilities that are available.
Okay.
Urgent cares are not. So there are urgent cares that have facilities for diagnostics such as X-rays. They have some of them have diagnostics like ultrasound, more point-of-care lab testing. So I think from a patient's perspective, it does make if you choose to go to urgent care, it does make a difference which one you go to, because some are better equipped than others for a kind of severity of illness. So that being said, if a patient has an ankle injury or sprained ankle, I think urgent care is a fantastic place to go. It's a very appropriate place to go if that urgent care has the diagnostic ability of doing X-rays and whatnot.
Sure.
I think it's quicker. It should be, in general, it's quicker.
Mm-hmm.
It's cheaper, from a copay perspective and from
Okay.
a healthcare cost perspective, it's cheaper. And it helps decompress the emergency department for patients that have higher acuity needs.
Okay.
And it allows those patients to get taken care of quicker.
Okay. It's interesting. I did not know that emergency care was pretty standardized across the board, and that urgent care was not. It sounds like there's some.
Yeah, so in California, and I say that because it's emergency care in California is a little bit different than outside of California now in the last 10 years or so. In California, emergency departments are hospital-based facilities,
Okay.
so they're regulated by all the hospital regulations and the both federal and state regulators. Urgent cares are not, and so they're kind of independent clinics, and they're regulated, but to a much lesser degree.
Okay.
And when I say that most emergency departments are standardized, what I mean by that is that in made in cities, like major cities like this,
Sure.
most of the personnel staffing emergency departments, from the physician perspective, are going to be board certified, board eligible, or have been what we call kind of grandfathered into emergency medicine, so doing it for decades at this
Okay.
point. And the personnel there the support staff will also be emergency room trained personnel. Most emergency departments in large cities will have CT scan imaging, X-ray imaging, ultrasound imaging, and specialty backup. So that's what I mean by standardized.
Okay.
Is that there's generally the abilities are pretty similar
Okay.
outside of specialty centers.
Sure.
Obviously.
But the costs are quite different. So if you bring a child to an ER with an earache, your bill at a minimum is going to run over $1,000.
Okay.
Upwards of $2,000 for an earache. If you bring a child to an urgent care center, your bill is going to be in the low hundreds, just based on what insurance will pay or uninsured, and how that visit's going to be billed or seen. So they are less costly, but at the same time, if you go to an urgent care with chest pain and you're having a heart attack, they can't treat you at that point. They have to call 911 to get an ambulance to take you to the closest ER.
One of the great things with the donor charity system too is that our urgent cares are associated with our hospitals, and so specifically at DePaul, if we have an issue, we have a relationship with the hospital, and the same for the other daughter hospitals. So we have that regulation that backs us up too, so that the urgent care has the backup of their strong emergency departments should they need it. Should a patient with chest pain show up and need to be transferred immediately, we have that capability to take care of that patient right away.
And many of the doctors that practice at the urgent care are also emergency room physicians at our urgent cares. So they are often the same physician that somebody would see when they came into the emergency department at St. Louis. They will work at the urgent care as well.
And that's not the same for most urgent cares, but in the daughter system, that is correct.
Okay.
Correct. All the daughters, urgent cares have X-ray capability. So we were discussing whether there's some that don't have that, but all of ours do. And I think all of ours have defibrillators too. So someone
So that's a real competitive advantage for you.
inadvertently goes into an urgent care because they are in denial about their chest pain being severe and they pass out. We can stabilize them until
Okay.
911 brings them to the hospital.
So, urgent care and emergency department messaging reads, "We've got you covered." Tell me how you have this community of covered, and how opening additional urgent care centers is part of the overall strategy for healthcare in the county. We'd like to take a shot.
Well, I think so. If you look at South County, where St. Louis is located, and probably 10 miles north in Morgan Hill, we have the DePaul Urgent Care.
Right.
At O'Connor, we have the emergency department, the hospital at O'Connor, and right across the street, the foundation just opened an urgent care 2 months ago, I think. Then on Lincoln Avenue, there's the Foundation Urgent Care. So I think when we're talking about we've got you covered, no matter where you are in the county, we can get you and have you seen in an urgent care if that's what you're looking for. And if you need that higher level of care, we can get you to one of our ERs to be seen. I think it's just saying that we can cover whatever issue you have. We've got the connection between the hospitals, urgent care centers to get those patients treated and taken care of.
I think we have to stop thinking about care so individualized with the new changes that we're seeing in this country. We are part of a system that can offer primary care, that can offer urgent care, can offer emergent care, or aftercare as well. So I think the whole transition in this country for healthcare is going toward covering the entire patient.
Okay.
Whether it's the inpatient, whether it's the ER visit, whether it's the urgent care, whether it's their outpatient care as well, labs and x-rays. And so as a system, the Daughter of Charity is working at that. And that's why we feel strongly about that tagline that we've got you covered.
Okay.
And just to add
Sure.
to that, the urgent care, although it is not the same as a primary physician office visit, the goal that I have as an urgent care director is that will be communicated to the primary care physician in a meaningful way, that the patient will be able to go to their doctor and they will already know that they were at the urgent care, what the issues were,
Right.
and have that communicated fluidly between the organization.
Okay.
The foundation is planning on opening an additional urgent care within the next year in the Almaden, South San Jose area.
Really?
Yes.
Okay. Got some news here today. I didn't know that. So we talked about this earlier, but it sounds like you have many of the same healthcare providers in urgent care that you have in the emergency department. Is that across the board with nurses and doctors and all of the staff, or how does that?
That's actually not completely accurate.
Okay.
The urgent cares, at least in our area, are not all staffed by emergency physicians, emergency nurses.
Okay.
Specific to Daughters of Charity, we have different levels where we feel that that's important.
Okay.
Especially in the South County where we're so far away from everything.
Sure.
But no, in the urgent care, and I think as Dr. Bowen also mentioned too, the independent clinics, in the outside areas, they pretty much can staff with what they feel. They may have a physician assistant only on site, or they may have medical assistants only on site. So it really is dependent on the individual site.
Okay.
Yeah.
And I would say for our area, so the two urgent cares that we currently have in our area that are with the foundation are not staffed by emergency department physicians.
Okay.
They're staffed by physicians that have been doing urgent care for many, many years and are very experienced, and they evaluate the patients. And any patients that they feel are out of their scope of practice, they have an open mind to us, and we'll transfer to the emergency department.
Okay.
As far as the staffing goes, I think it's variable depending on which urgent care you use.
Sure.
But most urgent cares are not staffed by emergency department nurses or personnel.
Okay.
They're staffed by registered nurses, licensed vocational LVNs, medical assistants, and just it depends on how busy they are.
Sure.
And the acuity of patients that they're comfortable seeing. And as the urgent cares that are more comfortable with higher acuity patients will have staffing that reflects that, I think.
Okay.
And then in our emergency departments, I know that, so we won't hire a nurse in our emergency department unless they have 2 years or greater experience. So
Okay.
you look at that level of experience they've had in the emergency setting. You look for nurses that have they're certified emergency nurse, so they're a specialist in their field.
Okay.
Versus the urgent cares that might hire a nurse who is fully capable of caring for the patients as in a doctor's office or in urgent care, but they're not trained in emergency nursing.
Okay.
So they're registered nurses, LVNs that are highly skilled in taking care of those type of patients, medicating those patients, drawing blood, doing those items that they would do in the urgent care.
Okay.
But ERs are staffed with primarily no LVNs. You see only registered nurses.
Okay.
And registered nurses that have 2 or more years of experience.
Okay. Anything else to add to that question?
No, I
Okay.
think we did a good job.
So I am interested to know what trends you see in the emergency department, and we can start over here with you, Doctor.
I think the trends that we're seeing in our community are really not much different than what we're seeing kind of nationwide.
Okay.
Which is a significant lack of access for patients. Predominantly in the underinsured population. So just lack of access to primary care and acute care. So,
Okay.
Even healthy young individuals will episodically, like we talked about, need care.
Right.
And there's a significant lack of access. So the emergency department is, I know this word is very overused, but it is the safety net for those individuals. So we see this constant, large flux of patients to the emergency department that most of those could be very safely taken care of in a primary care doctor or urgent care clinic environment. So I think that trend, which is nationwide, it's not a San Jose problem or a Northern California problem, it's a nationwide problem. I think on a more positive note, I think the biggest positive trend that we're seeing in the emergency department is a tremendous amount of effort and focus has now been placed on the patient experience. So something that wasn't really given much attention 10 years ago is now really a primary focus of most emergency departments. So, the emergency department is no longer a place where a 2-hour wait to see a provider is acceptable. It's absolutely not acceptable.
Okay.
And I think every department in the county and probably the nation is making a lot of effort to becoming very high efficiency facilities where you can see a lot of patients quickly and safely. So I think that's a very positive trend that's happened in emergency medicine in the last 5-10 years probably.
I think the emergency department is very efficient. I think last year in 2012 we saw over 130 million people in the United States came through the emergency department, and the percent of the U.S. health dollar is only 2%. So we're looking at treating the sickest of our sick patients at a huge number, it's 130 million, with using a very small amount of our healthcare resources for this country. So I think what we need is more resources and not less.
Okay.
There are mandates for us. We can't turn a patient away, nor would we.
Right.
But those mandates are not funded by the government. They're not funded. So we're hopeful that the new healthcare changes will provide some really needed impetus to get patients where they should be, instead of having, to use us as a safety net. And we're seeing a lot sicker patients in the emergency department as a trend, and we're seeing the volume just skyrocketing. I think I heard that.
And most of those people are uninsured.
Not necessarily.
Not necessarily?
Or they can't
Okay.
they can't access primary care. There just
Okay.
aren't enough primary care doctors to take care of these patients.
Okay.
And I don't know how that's going to change in the near
it seems
future.
like that's going to get worse because there is now a mandate that everybody have health insurance, which is going to impact the number of people looking for primary care physicians. So if it's tough to get in to see the doctor now,
It's going to get tougher.
it certainly seems to be going to get tougher.
Interesting number that in the United States, at least, about 1 out of 5 adults and about 1 out of 4 children under 6 have to go to the emergency department every year, or have gone to the emergency department every year. In our South County, we just did a recent survey that found, at least in the Gilroy population, about 1 out of 2 people had gone to the emergency department in the last year.
Half.
Yeah, someone in their family.
Okay,
I misspoke.
sure.
Someone in their family had gone to the emergency department in the last year. So we're seeing a huge number of people needing to access this with resources that are really quite limited. But at the same time, I think we all deserve a lot of credit. We're doing a great job, serving the population.
So I want to follow up on this then. So how do you create, or how is the Daughters of Charity creating this great customer experience, this patient experience, with being stretched for resources? Because those are tough things to do in sync.
It's challenging. I mean, so we work with our staff to, you think it's not only is the patient, so hospitals have moved towards where they're not patients anymore, they're customers.
Right.
And so not only is the patient our customer, but the lab is the ER's customer. So it's about improving those relationships to improve the ultimate goal of meeting the patient's needs. So 10 years ago, 10 or 15 years, as Dr. Mamani was stating, ERs didn't really communicate much. You came to the ER, you were seen, you were discharged, you followed with your doctor. We now work at making sure when they come in, a patient comes in and they give us their primary care physician, that we're sending the documentation of what was seen on the visit for that patient to their primary care doctor within a day or two.
Okay.
It's automatically sent, so they have that communication. But just working with the patients, trying to, families are busy, and so they've been at work all day and they come home and they've got a sick child. They don't want to spend 5, 6, 7 hours in an ER.
Sure.
And so we're working to improve our processes so that we are seeing that patient as fast as we can to get them back to their normal state of life. Really improving that experience. Communicating with the patient's huge. Trying to let them know what the processes are going to be, what's going to be happening. Labs, X-rays, the time frame, so they can plan their lives a little bit more. So it's that trying to improve that communication and treating them, the patients, as customers that have a choice to seek care where they want to.
I think it's safe to say that the patient often sees hospitals as very siloed. And so what you're talking about here today, whether it's urgent care to emergency care to a hospital stay, it's pretty integrated. I think that's accurate? Yeah. Okay.
And it's going to get more integrated.
It's going to get more integrated?
It's going to get
Expand
more
on
integrated.
that.
You won't have to sign, he won't have to send fax or send anything. It will automatically end up going to the doctor's electronic medical record.
Okay.
So when he comes into the office, or she comes in the office the next day and she opens up her computer and looks at the patient, it's going to be right there.
It's all there.
So that's our goal is to manage for today. We're looking at what's happening, and the staffing is increased. We increase staffing to meet what we figured out is the demand. But our goal in the long run is to produce more value, to manage the situation and care better, and have coordinated care, so people can be taken care of just as well or better, but with more value, with less cost, because they'll be at the right place with the right person at the right time.
Great. I think it's a great story in that there are those real perceptions about healthcare and hospitals and how it's all linked together, and it sounds like what you're doing at the Daughters of Charity is pretty integrated. So, you've mentioned that more and more people are using the emergency department rather than going to their physician or to urgent care. And I want to, and a couple of you have brought up healthcare reform, so now would be an ideal time to talk a little bit about that. Is that going to improve or change because of healthcare reform, or does it all matter that we go out and find a bunch of primary care doctors that will fill the void? And I'm going to put that out to anybody because I see a couple of smiles on the table. And so if anybody wants to start with that first, please do.
I think in the short term, we're going to see a huge influx of patients into the emergency departments. And as I said, I think we're going to have to, as a country, as a nation, figure out how we're going to allocate resources for that. In the long run, we need to see a much larger base of our primary care physicians. But that's going to take working with the medical schools, and even more importantly, working with the hospitals and their residency programs.
Okay.
Because I think that is more of a limiting factor right now, even in the medical school students who are coming out. But as far
And
as
why is that?
And why is that? Because the Medicare funding has been cut for those residencies, and although we're all in tune with trying to get more primary care physicians, there aren't the number of residencies to train those students.
Okay.
And so in this country, it's not just about getting everyone insured, it's about getting physicians who can care for those patients. And we haven't addressed that adequately in this country yet. The medical schools at this point, to my knowledge, are working on increasing their numbers, increasing the, I would say actually, flexibility in their curriculums to promote more primary care and getting physicians trained that way. But our residencies, and specifically because of Medicare funding drying up, they just don't have the ability to bring in additional residents in these programs. So we're not going to see a change anytime soon. And so in the short term, I think it's the emergency departments and the urgent cares that are taking up the slack. And I think that's an issue that has really not been addressed very well with the new changes in the healthcare system.
I know one of your questions coming up is about what have you done to improve flow, but even as of yesterday, we're talking about what else we can do. We've made a lot of improvements in our flow.
Sure.
What we were talking about yesterday, we're doing some other build out because as the winter season comes up, our volume goes up. We were seeing, I think, 54,000, 55,000, and we're slated to see over 60,000 this year. So we have to realign our processes so that we can see those patients when they come. It's still in a timely manner, catching the ones that are critically sick that need to be back in the back right away, and siphoning off the ones that really don't require the emergency medicine so we can get them seen and treated and out in a timely manner so we don't tie up beds in the back. But we're looking just for the winter about what we're going to do with increasing staffing, anticipating our volumes and what they're going to be.
How do you manage that?
As far as staffing and
Yeah.
so we look at numbers from the past year, we look at what we've run through the summer, and we meet as an ED leadership team. We look at what we potentially have coming in, how we can better allocate our resources for staffing, for nurses, for physician coverage. Thankfully we've got good physicians that are really willing to add the resources when we need to add an extra physician or increase a physician's hours. Same thing with nursing. We can add a resource, but we pair them up so that we can take care of the most patients at one time,
Okay.
to get them seen and out.
So I think although we expected the Affordable Care Act and the changes in that we call Obamacare to cause a lot of confusion and insanity in the beginning, like it's doing, I think eventually it's going to land us in a positive way. And we're going to, the foundation's looking at really how do you manage a population? What do you do with population health? How can you prevent people from going to the hospital or going to an urgent care when they just need an advice nurse to talk to them? How can you make sure that people get into the right service line, waiting the next day to see their doctor and getting into their doctor's office? We're going to have to be creative. If there aren't enough primary care doctors, we're going to have to sort of start interjecting nurse practitioners and physician assistants into the doctor's office to work as a team. And we have to develop primary care offices that have more help, so they have more staffing that can help the patient and talk to them about their smoking or increasing their activity or exercise, and the physician can go on and handle an abdominal pain of a patient that obviously the staff cannot evaluate.
Okay.
So I think in the long run, we're going to have a more efficient system that has more value, that has better outcomes, and better patient satisfaction.
Anything else to add on that question? Sure.
No, go ahead.
I think a key component kind of moving forward back to this healthcare reform
Yes.
issue and a large number of patients that I think we anticipate kind of have with an influx is education. And I think as part of the healthcare reform, I think the government has a responsibility for intense education, and all healthcare providers, I think, have a duty to kind of educate patients on appropriate access points for appropriate illnesses. I think the healthcare systems internationally that work, there's a much the access points of healthcare are used more appropriately than I would say in this country. Right now the emergency department, which is the most expensive place to get care on a per case, is used for things that many times don't need to be, and it's not patients' fault. I mean, they've never been educated on what else they could have gone.
Sure.
And so I think one of our efforts now with the foundation urgent cares is as to our patients, we are giving them that information at discharge, not telling them and letting them know of this is in our daughter's system. These are the different access points. We have a primary care. A spectrum of primary care offices. We have currently 3 urgent care systems and 2 emergency departments. These are your options, and we can try to explain for what cases they can kind of go to different access points. And I think that's a critical part of in the next few years of having patients educated on where they should go for what.
Last word on this?
I think you guys covered it pretty well as
Okay.
far as the Obamacare and how it's going to change. I'm going to wait until we talk about we can talk about efficiency and how we're doing.
Let's talk about that.
Sure. So what we're really working on in our emergency department, and we see about just shy of 30,000 a year, but we see them through only 8 beds, which is for the size of our emergency department, it's about 2.5 times the national average of patients per bed per day. So St. Louis is very, very efficient, and we continually, one of my primary jobs is to maintain that and improve on it, and improve the patient experience from beginning to end. And one of the big things we do is RME, which is kind of a rapid medical exam. Our door-to-doctor times are around 12 minutes, so it takes about 12 minutes on average from the time you hit the door to actually get face-to-face with a provider.
And that's part of the changing patient experience that you
Exactly.
mentioned earlier.
And we're really focusing on, not sitting in the waiting room for an hour or two. Historically, triage was used as a almost a barrier to care. And the idea in modern that we're all trying to implement is that the triage process is as eliminated as possible, so that there aren't barriers to getting the patient from the lobby in front of the physician.
Okay.
Because the quicker you do that, the quicker you can discharge them as well. And so we have rapid medical exams, which the PA will oftentimes see the patient in
PA,
physician assistant.
physician assistant.
So we have physician assistant coverage, and at our emergency department, the physician assistant will often see the patient in triage minutes after they arrive and begin all of the testing that's needed for the care of that patient. And they may be a very complex patient that's going to require an emergency department physician management. But the idea is to get the bulk of the testing and the bulk of the plan of care outlined as rapidly as possible, so that if the emergency department physician is backed up a little bit, everything has been ordered, and we can get them taken care of as quickly as possible.
And is this something that's specific to the Daughters of Charity system? Again, this is part of a competitive advantage you think that you have?
I think we do it better than most places. We were
Okay.
just at the conference in Los Angeles for California Emergency Physicians, and St. Louis was recognized for not only our patient satisfaction but our throughput and efficiency. We were one of 5 hospitals or so that was highlighted in the main presentation regarding that. So
In general, we like to think about things as team care. So
Okay.
our physicians, our nurses, our PAs, all of us working together to get the patient the right place, the right time, and get them through quickly, or into the hospital if they need it, or to their primary care. So that's kind of our concept for the patient care experience, using this team care approach, and I think we're all pretty much doing the same sort of programs here.
We've really worked in the past year to restructure, so we're different in EDs. We're lucky to have an ED that was opened in 2005, so it's more modern. We have 23 beds, but we looked at our processes when I came on, and Dr. Bhamani and the ED leadership team got together. We were having problems with door to EKG times, so the patients coming in with chest pain and really trying to ascertain if they're having an MI, a myocardial infarction at the time, and if we need to get them to the cath lab. Looking at left without being seen rates, patients that come in would sit in the waiting room, wouldn't be able to see a doctor, and they'd leave. So we really took a hard initiative at looking at our process and redeveloped it starting on January 2nd. We've initiated a few processes. It used to be when patients came into our ER, the first person they'd see was a registration staff, so a non-clinical staff. we'd have a line of 15, 20, 25 people waiting out the door to be registered. We couldn't tell who was there for what. So we moved that person out. We put a nurse there and called it a greet nurse. So now when patients come in, they're assessed by a nurse quickly and put in the system within 45 seconds. And they either see, at that point, they either see a physician, the triage nurse, or registration staff to get the paperwork started. We've reduced our door-to EKG times from 30 minutes down to 4 minutes. We've reduced our left without being seen rate from 4.5% to less than, I think we're at 1.4%. Our overall, because reimbursement for the hospitals from the government by core measures, so they're tracking your door-to-balloon times for cardiac patients, door-to-antibiotic times on pneumonia patients, and all that sort of initiates and starts with those patients coming in through the ER. So you have to be on the ball,
Sure.
recognizing who's there for what, so you can get those measures and that patient treated with the best care in the quickest amount of time.
Sure.
So that you can get those interventions started. So that first of all, the patients are surviving, they're doing better, but also that the numbers are reported to the community and to the federal government, so reimbursement comes back in, because it's hard for hospitals to survive with Medicare and Medicaid and the different reimbursement. But we've improved door-to-balloon times down to an average in the county of 57 minutes, which is the time from the patient arrives till the time they inflate the balloon to fix the blockage, an average of 57 minutes. So just restructuring our flow, and just like I said, we've been talking this week, we're actually going to build out another portion of our ER, because as they run RME, we run a fast track process.
Okay.
And 3 to 11 every day, 7 days a week, we have a doctor and a registered nurse that run the fast track for 8 hours, sometimes 9 hours a day, that when the patients come in that would typically at 3 o'clock in the afternoon be sitting in the waiting room for 2, 3, 4 hours waiting to be seen because every bed's tied up, that doctor and that nurse see each patient order of arrival. They'll start blood work, they'll start x-rays and get those done so we can actually keep the patient from having to lie down on the bed.
Sure.
We can keep them moving and get them assessed quickly and get treatment, so we can discharge them from there instead of them tying up a bed, allowing the beds to be open for our more critical patients.
I just want to add, this is not unique. I mean, besides the Affordable Care Act and what's happening now, the government has been making changes and telling healthcare providers to do certain things that have really improved the care of patients and have saved lives that weren't saved before, and making hospitals be safer place for patients, less accidents across the country. It's really been a tremendous change we've seen in the last 10 years because of what Medicare has sort of driven.
Okay.
You asked about the system being, whether our processes are competitive advantages, I think. And just to clarify that, I think every emergency department has unique challenges based on the kind of layout, the geography of the department,
Sure.
the age of the department, and so there's not one solution that works for every department.
Okay.
What the best practice for us may not work at a different facility if the layout is different. I think that the key thing is that St. Louis and O'Connor both have developed processes that work extremely efficiently and well for our facilities. So,
Okay.
St. Louis has developed a system that is, as you heard, is highly efficient for the St. Louis facility. That system may not work at O'Connor, but we've developed a system that is very efficient for our layout and our staffing and our model. But the key thing is that it's the same model is not going to work everywhere. But I think it's critical that every hospital develop, or every emergency department develop, a model that works. And I'm pretty proud of the two systems that we've developed because they work.
So there's a lot of best practices available out there if you're a
There's a toolkit. I mean, it's you go and learn many different techniques to achieve all these goals, and like Dr. Mariah said, it's really figuring out which works best with your staff and your physical layout, and the ancillary services too. Some facilities have very strong radiology departments, and so finding out what works is the key, and then continuously improving them.
Sure.
Our goals are all the same, and I think, at least for the daughter of Charity Hospital, we've all put that's our motivation. The patient experience is our charge right now, and that's what we're working at, being more efficient and improving the patient care experience.
Now, Doctor, earlier on you brought up electronic medical records, and so how does my information get back to my primary care physician after some time in the ER or at urgent care? How does that work now?
Well, our urgent care, or two of the urgent cares, the ones that the foundation runs, the number of physicians are on the same platform.
Okay.
So whatever is put in the electronic medical record is in the patient's chart. Unfortunately, with the whole foundation, we have about 10 different electronic medical records.
Okay.
So getting a health information exchange is our goal at this point of time.
Okay.
So there is instant communication.
Okay.
But presently, we are faxing records from our urgent care to the primary care doctor's office.
Okay.
Similar to what the hospitals are doing.
And if I don't have a primary care physician, is that just sitting on the system somewhere, or how does that work?
Patients are always given a referral to someone.
Okay.
And that's usually
All right.
dependent on their their insurance or their medical needs or their previous history with other physicians. So someone is whoever is seen in an outpatient setting, whether the ER or the urgent care, they're always given some sort of referral, and that's something we all do, just so that they have a way to access care after their episodic care with us as well. And there's different techniques. We're very lucky to have a very strong, technology has improved so much. Both the ERs have a program that's very strong, working with coordinating the lab and the x-ray
Okay.
and the visits we've seen and their past medical history and their past medical records. So that's great. I can, see you as a patient and pull down right away the last, 20 times you've seen us. So hopefully not. But in any case, technology has really improved the way we're able to care for our patients, especially in these settings.
In our system in the ER, the Pisces IDEX that we both use, if you come in and you have a primary care doctor that you see, the registration staff will put that in the computer and they interface, and when the visit's done, it now automatically sends an electronic copy to the doctor's office. So if they list one, it'll send a summary of what Dr. Bomani's care was for that patient to the doctor's office. So the next morning when they come in, they can see and say, oh, well, this patient was seen, and they know what the care was.
Okay.
A lot of systems in the county, there's not a lot that blend that can do that. I know that we are one of the organizations that are assuring that we get that to the physician office.
Okay. Okay.
And then typically back to your question about what if I don't have a doctor,
Right.
in addition to what Dr. Stewart said about giving people resources to establish with primary care, generally, we if they've had an extensive workup or an evaluation, in the emergency department, we, with our discharge instruction, print out all of the lab results, copies of their x-rays, whatever we feel like they're going to need at their follow-up appointment. Because most of those patients that have extensive evaluations need some follow-up appointment.
Right.
We've been fortunate in our system that with the new foundation urgent care opening up very close to the hospital, that patients that don't have absolutely defined follow-up and that the emergency department feels need follow-up, often we will have them follow up in the urgent care. And we can give them times, and they have access to all the data, and then the urgent care at that follow-up visit will then try to establish them with a community physician.
Okay.
So it's our backup system to make sure patients are seen and followed from the emergency department, and that's been a very, very helpful for a lot of our
It's a system
patients.
way of increasing value, because they're not going back to the emergency room and with the $2,000 entry.
Right.
To get a follow-up visit. At least if the visit turns out to be charity, at least the value of it is much better for society and for the Daughters of Charity.
I think that's why we're so big on educating the patients where they need to go, because lay people come in that aren't in the medical, even
Sure.
CEOs of companies, they don't know how to medicate their child for fevers, and so that's part of our job, is to educate those people those patients on where to follow up, how to treat themselves, what they need to do to care for themselves. And so trying to drive them to where they get a primary care physician so that they don't end up, like some of our patients come in that are near death that could have seen a primary care and had some intervention a few weeks prior, but they haven't had that opportunity. So trying to drive them in that direction so they obtain that primary care is important.
I'd just echo that. I often emphasize with the nurses how important, I mean, that's really the benefit that the patient gets from the emergency department visit. There are many patients that will come in and the emergency department physician will see them, and there's really no medication intervention that's needed, or even a procedure or anything, and so they have that $1,000 or $2,000 entry fee to see the emergency department, and really at the end of the day, what they're getting from us is education about their condition and how to get access into the system as a whole, more appropriate points of entry. Okay. And we spend a lot of time emphasizing that with the staff and with the patients.
Okay. So I'd like to ask about the day in the life of an ER doctor.
It's a very tough question to answer, and the reason is that no 2 days are the same, and I think that's in some ways the beauty of our job. When you wake up in the morning, you never know what your day is going to bring. In fact, when you're working, you don't know what the next hour is going to bring or the next 10 minutes are going to bring. And I think that's part of what, at least for me, that's part of why I love the job so much. In general, the kind of the art of emergency medicine, I think, is managing many different patients of multiple patients at a time of varying acuity, but making sure that you give each patient the time that they deserve. So when you're in my goal is when I'm sitting down with the patient,
right,
they should never know how busy I am on the back end. When I'm in there, I'm there for them, and I think that's the art of the job. But we see everything. We enjoy seeing a lot of different disease processes. It's a busy. It's very much of a team environment.
Mm-hmm.
We are only as good as as the staff that we're working
Sure.
with. So I think a lot of it is promoting a team atmosphere, and that's what makes the job fun. Because we don't work by ourselves. We're working with the team, kind of with the same goal. Every day is different. We get to do a little bit of everything, which is fantastic.
That's great.
I think we're all specialists wrapped into one some days. And we all have days where it's just sheer chaos sometimes. But the emergency physician and the emergency team of providers, the staff, et cetera, are trained to handle that chaos. And I can tell you, yesterday, saw a snake bite, saw a trauma, saw a heart attack and a stroke within 5 minutes of each other. So, some days it is things that would really frighten a lot of people, but I think the ER is there and the prices are high because we're the trained people to do it.
Right.
And as we've kind of laughed a bit or talked about the finances a bit of how expensive it is, but what we're doing is providing 24/7 access to any specialist at any moment, at any second of the day. And we're taking them from everywhere, from the helicopters, from the ambulances, from the people walking in, to the gang members dropping them off and running.
Mm-hmm.
So I think, you can talk about a day in the life of the ER doctor, but I think he said it right. It's really a day in the minute because it changes moment by moment. But we love what we do, and it's rewarding. Not all the times, but it's rewarding, often enough.
I think controlled chaos is like the word that I
Okay.
would use. That to many people, if you just came and if you were a fly on the wall of the emergency department, watching what's going on in the hallways and the interactions that we're having with our staff and on the phone, it might seem very, very chaotic, but the beauty of it is that it's not. It's very it's controlled chaos. Even when somebody who's critically ill just comes, like Dr. Stewart said, comes through the door, there's a lot of activity, but there is a plan with that activity. We've done that before. We've seen it before.
It's like a coordinated dance.
It's a
Yeah,
dance, right?
it is,
It's a dance.
and that's what we thrive on. I mean, that's what we love. That controlled chaos of the emergency department. A slow day, we do this for those days. Those days,
I always joke to the staff that emergency departments run better when it's busy.
Right.
They really do. The days
Interesting.
when there are a few patients trickling in and the beds aren't full, they're not as efficient as they are when every bed is full. You have to use resources as efficiently as possible, and you have to identify what needs taken care of and how rapidly.
I think most people go into ER medicine, ER nursing, because they appreciate and thrive on the adrenaline rush
Sure.
that you get from not knowing what's coming in. It's different I worked ICU for many years and grew very tired of that. Though I loved caring for the patients, you would see the same patient over and over again, and you develop these relationships with them. And if they passed away, then you had this loss. Working in the ER, though you get to recognize a few of your frequent people that keep coming in, it's constantly something different. It could be a lady delivering a baby. It could be someone having a stroke, someone having a heart attack. And you're taking this person from the point they come in, whereas if they're admitted already, they're stabilized. They have everything,
Right.
and you are working to stabilize them. And so there's an adrenaline rush there that comes with not knowing what's coming in, being excited what can potentially come in. I think that's just the staff in the ERs. That's what they look for.
We tend to see patients, I think, when they're truly most vulnerable. They're coming to the emergency department with themselves, with a loved one, often not knowing what's going on. Am I having a heart attack? Am I having a stroke? And that's where we get to intervene. And I think that's a very, very kind of special place to intervene when people are from an emotional perspective at their worst.
Sure.
We have an opportunity to make a change, and that's a big part of our job is to treat not just the patient, but you treat the patient's family and their loved ones and everybody else.
It's satisfying, I think, because you get immediate gratification. Someone comes in pain, you can give them some meds, and they're calmed. They feel better. You feel better because you've relieved that pain. So I think there's some immediate gratification with ER nursing and ER medicine, just being able to make a difference in someone's life right then.
Great. Is there anything that we have not covered here this afternoon? We've talked about integration. We've talked about healthcare reform. We've talked about electronic medical records. We've talked about urgent care, ER care, primary physicians. We've done a lot in 45 minutes.
I think one thing I might mention too is with our system, with the Daughter of Charity, we have the availability of multiple specialties to really, we've talked about covering all areas of care.
Okay.
And St. Louis is a smaller hospital, but at the same time we have the ability to work with our sister hospital at O'Connor if we need something that would not be available. So
Okay.
that's very, I think that should be reassuring for the community too, that we have the availability to share resources, to get the best of the best for those patients when they need it, and in a timely fashion too. So coordinating as a region, as a regional center, the two hospitals, has really been, I think, a bonus for the community as well.
Terrific.
I think that we got you covered that slogan. I know that right now our hospital has the best door-to-needle time for stroke in the county. So the patients that come in that are having a stroke that we give TPA, we've got the best times there. We're working and almost, we were just recognized at the last county meeting for our door-to-balloon times for the STEMI patients. So just really working as a group and as an organization to improve that care is really improving what we do.
Certainly, our long-term goal is to improve transitions dramatically. So we're talking about just an urgent care and ER in different silos, but patients go from the emergency room into the hospital, and we want to make sure that care is coordinated.
Okay.
So the hospitals need to come down with a certain amount of time, see the patient. There needs to be communication, and treatment needs to be continued at an appropriate pace. Then when the patient leaves the hospital, going back to the primary care doctor or a skilled nursing facility, you have to make sure that there's coordination in their transition. Everybody communicates well. And then if the patient's in a skilled nursing facility and has to come back to the hospital, going back to the emergency room, we want to make sure that there's appropriate communication for those patients, and that everybody knows what the plans are for the patient, whether there's an advance directive or what's
Sure.
called a post form that is delineating whether care is limited or not based on the patient and family's preference. So I think those are our goals to have you covered,
Right.
is to have a whole system that works together in a coordinated way.
Great. Thank you all for your time. This was
Thank you.
terrific. Thank you.